everyone. Thank you for joining today's APM Performance Pathway webinar. Today's call will provide an opportunity for participants to ask questions about the 2021 Alternative Payment Model, or APM Performance Pathway, for clinicians and support staff who would like details on the APP, especially Shared Savings Program ACOs, who are required to report using the APP in 2021. Now I'll turn it over to Corey Henderson from the Innovation at CMS to begin.
Good afternoon, everyone, and good morning, depending on where you are in the country. Thank you for joining the 2021 APM Performance Pathway Overview. Next slide. We'll move through these slides today with some opportunity for question and answer at the end, so we don't want to rush through the slides, but we're also not going to take too much time so that we can really focus on the needs of you, clinicians, and your support staff. The reason for this disclaimer here is that this slide deck is a summary. It is not a legal document, nor is it all information that you'll need to know about the APP. So we encourage you to go and learn about the APP, and if you do have to leave this slide deck, when we do make it available, there are resources at the very end that we'll share with you to learn more. Next slide, please. Today, we're going to really focus on a few areas. The overview of the Quality Payment Program, just to give you some background, the overview of the APP, the overview of the APP, the APM Performance Pathway for the Shared Saving Program ACOs, the APP submissions, the APP scoring, resources, and the question and answer period. Today's focus, again, is to provide you with the resources that you need so that you can be successful. And as always, we're listening to you, we heard you, and this presentation is a direct result of you stating that you wanted to learn more so that you can be successful in submission, scoring, and knowing about the APP. Without further ado, Brittany.
Thanks, Corey. Can we go ahead to the next slide? Thanks. So, as many of you are likely aware, there are really two tracks within the Quality Payment Program. The first is the Advanced Apm Track, and for participants who are in Advanced APMs, they have the ability to earn QP status and be excluded from MIPS and earn an incentive payment. We're not really going to talk about that side of things too much, but rather we're going to focus more on the MIPS track of the Quality Payment Program. So if you're a MIPS eligible clinician, you're not a QP, you may be subject to MIPS and the performance-based adjustment based on it. And also, again, Shared Savings Program ACOs are required to report through MIPS as well. Next slide. Again, this slide goes into a little more detail about who among APM participants are required to report to MIPS and who may not be. I think the more important takeaway for this particular webinar is if you do not earn QP status, you will receive a MIPS payment adjustment unless you have some other exemption. And again, Shared Savings Program ACOs, you're going to have to report through MIPS regardless of your QP status. So what we're talking about here related to MIPS eligibility is going to be applicable to you as well. Next slide. When we're talking about folks who are eligible for QP status, what we mean are people who have crossed the QP threshold and are in an advanced APM. And people sometimes get a little confused on this point. All advanced APMs are MIPS APMs. So there's a little Venn diagram showing sort of the nesting of the different types of APMs. Really, the point here is to show that just because you're in an advanced APM does not mean that you are necessarily excluded from MIPS. These conversations are still important, which you probably know because that's why you're on this webinar. So let's just go ahead to the next slide. And the threshold that I mentioned for you to be able to become a QP is currently set at 50% for the payment amount threshold and 35% for the patient count threshold. That was set to go up, as you may or may not be aware, but it was frozen at this level through the Consolidated Appropriations Act of 2021. And so it will stay at this level through performance year 2023. Next slide. So if you're in an APM and you have to participate in MIPS, what does that mean? It means that you're a MIPS eligible clinician, and that means that you can report to MIPS in the same way as any other MIPS eligible clinician. You may report as an individual, you can participate as part of a group, you have the option of participating as part of a virtual group, which we won't spend a lot of time on because there just aren't very many of those. But if you have specific questions about virtual groups, please pop them into the chat and we can address those separately. But what we're all here to really talk about is like MIPS APM entity. So individual, group, APM entity group, these are all ways that you can participate in MIPS, even if you're a participant in an APM. If you participate as part of an APM entity group, you will automatically have the cost performance category reweighted to 0% of your final score. And again, you can participate in any way that any other MIPS eligible clinician may participate. So that means traditional MIPS or going forward, MIPS value pathways are available to you also. You can pick the measures that make the most sense for you. In addition to that, we have created the APM Performance Pathway. And this is a reporting option that is just for APM participants, and it's a little unique. So let's go to the next slide and we can talk about that some more. The APM Performance Pathway is a reporting framework. Again, I mentioned it's similar to the MVP framework that is only for APM participants. And you can report the APP as an individual, as part of a group, or as part of an APM entity. And you could do all three if you wanted to. Regardless of how you report, at the end of the day, CMS will assign you the highest score you have earned when we're calculating your payment adjustment. So if you participate in an MVP as part of a group and you report the APP as part of an APM entity, whichever one gets you the highest payment adjustment, that's the one we're going to use. And what's interesting about the APP is that, or what's I guess different, is that it's a fixed set of quality measures for each performance category. And here really we're talking about the quality performance category because within the APP, the cost performance category has been reweighted for everyone. And the improvement activities performance category, you automatically get 100% because you're an MIPS APM. And so that really just leaves the promoting interoperability performance category, which is the same for the APP as it is for everyone else, and then the quality measure set. So let's go on to the next slide. And within that quality measure set, we have 6 measures that are really available for everyone and anyone to report on. Currently, we have the CAPS for MIPS survey, 2 administrative claims measures, which are the hospital-wide readmission measure, and the MCC. Let me think. For 2021, the MCC, the multiple chronic condition measure, is for ACOs only. We've proposed to include the MCC measure for everyone else for groups going forward after performance year 2021. We also include 3 ECQMs or MIPS CQM quality measures that would also have to be reported as part of the APP. For 2021, we have finalized an extension of the CMS web interface for shared savings program ACOs only, and they can report on the 10 CMS web interface measures instead of the 3 ACQM measures, but they will still be scored on the CAPS for MIPS survey as well as the 2 administrative claims measures. Next slide. And as I mentioned, for 2022, we are proposing to extend the web interface into future years for 2022, going into 2023. For 2023, there are some additional requirements that would be applied, again, only to shared savings program ACOs, and we do actually have someone from the shared savings program who will go into a little bit more detail on that for you, I believe. Next slide, please. Okay, and let me turn that over to Sabrina, and she can continue to talk about some of the nuances for Mssp ACOs.
Okay, thanks, Brittany. Good afternoon, everyone. So in the next few slides, I'll be reviewing the APP policies for Shared Savings Program ACOs. Next slide, please. So on this slide, we describe the quality reporting requirements for Shared Savings Program ACOs for performance year 2021. So for performance year 2021, ACOs, as Brittany had described earlier, they're required to report quality data via the APP and can choose to report either the 10 measures under the CMS web interface or the 3 ECQMs, MIPS CQMs. In addition, ACOs are required to field the CAPS for MIPS survey, and CMS would also calculate 2 measures using administrative claims data. And then based on the ACO's chosen reporting option, either 6 or 10 measures will be included in the calculation of the ACO's quality performance score. Please note that ACOs that choose to report the 3 ECQMs, MIPS CQMs are required to meet the data completeness requirements for all 3 measures as described on this slide. Next slide, please. So on this slide, we describe the quality performance standard that will be in place for Shared Savings Program ACOs for performance year 2021. The quality performance standard is the minimum performance level that ACOs must achieve in order to be eligible to share in savings earned, avoid maximum shared losses under certain payment tracks, and also avoid certain quality-related compliance actions. So for performance year 2021, an ACO will meet the quality performance standard if the ACO achieves a quality performance score that's equivalent to or higher than the 30th percentile across all MIPS quality performance category scores, excluding entities and providers eligible for facility-based scoring. Next slide, please. In slide 15, we describe an additional requirement that ACOs are subject to in order to meet the quality performance standard under the Shared Savings Program. So for performance year 2021, if an ACO does not report any of the 10 CMS web interface measures or any of the 3 ECQMs, MIPS CQMs, and doesn't field a CAPS for MIPS survey, then the ACO would not meet the quality performance standard for purposes of the Shared Savings Program. Next slide, please. So on slide 16, we describe the proposed revisions to the quality performance standard for shared savings programs that we included in the calendar year 2022 physician fee schedule proposed rule. The proposed revisions are applicable to performance year 2022 and subsequent performance years. We propose that an ACO would meet the quality performance standard for performance year 2022 if the ACO reports the 10 CMS web interface measures and achieves a quality performance score that's equivalent to or higher than the 30th percentile across all MIPS quality performance category scores, or if the ACO chooses to report the 3 CQMs, MIPS CQMs, then and meets the data completeness and case minimum requirements for all 3 measures, and achieves a quality performance score equivalent to or higher than the 30th percentile of the performance benchmark on at least one measure in the APP measure set, then the ACO would also meet the quality performance standard in 2022. For performance year 2023, if the ACO reports the CMS web interface measures and at least one ECQM, MIPS APM measure, and achieves a quality performance score that's equivalent to or higher than the 30th percentile across all MIPS quality performance category scores, then the ACO would meet the quality performance standard. And then in 2023, for the ACOs that choose to report the three ECQMs, MIPS APMs, the same policies that we proposed for 2022 would also apply to 2023. And in 2023, if the ACO doesn't report at least one ECQM, MIPS APM, then we propose that the ACO would not meet the quality performance standard. For 2024 and subsequent performance years, we propose that if an ACO reports the three ECQMs, MIPS APMs, meets the data completeness and case minimum requirements for all three measures, and achieves a quality performance score that's equivalent to or higher than the 40th percentile across all MIPS quality performance category scores, then the ACO would meet the quality performance standard. So that is the end of my presentation. I would now like to hand it over to Damon Watkins, who will discuss APP submissions and scoring policies. Thank you.
Okay, thanks, Sabrina. Let's talk about APP submissions. Next slide. So who can actually submit to the APP? So I think Brittany mentioned earlier that MIPS APM participants can report to the APP at the individual, group, or APM entity level. However, it is required for SSP ACOs. Third-party intermediaries, such as qualified registries or QCDRs or other health IT vendors, can report the APP on behalf of MIPS APM participants. In addition, if an APM participant has the ability to report their own data, they can do that as well. We've received a number of questions recently whether or not an APM participant was required to use a qualified registry or QCDR. They are not. If they have the capability to report their data on their own, they can do that. They would do that by submitting the following types of file submissions. So QPP allows for QPP JavaScript object notation files, which is a approved CMS specification for submitting QPP data. We also accept quality reporting data architecture 3 files, better known as QRDA 3 files. This is also a file accepted by QPP for data submission. And there's also a QRDA 3 document that is available that provides the structure in which you can report your APP data to QPP. It's actually the QRDA 3 implementation guide that's available and provides information regarding that specific file structure. The data can also be submitted using the actual QPP portal user interface. Submissions done in the QPP portal do require a user role. So if you are reporting on behalf of an APM entity or ACO, you will need the APM entity user role to actually report data at that level. We also allow for direct submission. I'm sorry, next. Yeah, I'm sorry. We also, go back to the previous slide. We also allow for direct submission via the API or application programming interface. So the API is a tool that allows third-party intermediaries such as QCDRs and registries to enter submissions submission data directly from their EHR. So it's like a system-to-system submission. And so it allows for submissions via the API, and you can bypass the actual user interface by using the actual API. We also calculate claims to quality for practices or APM entities that meet the criteria. So if you report claims using the measure HCPCS codes or CPT codes, and your APM entity or group is 15 clinicians or less, and we will calculate a claims to quality score for you if those measures are present. Also, as Sabrina mentioned, we also allow web interface submissions for SSP ACOs. So SSP ACOs have the option of submitting web interface or the 3 MIPS CQMs or ECQMs, or both, and we would award the highest score. Next slide. All right, let's talk about aggregating your data for your APP submissions. So one thing to note is that if you're reporting at the APM entity level or ACO level, this means that you are reporting on all clinicians in your APM entity. And your submission should include aggregated data for all patients and all payers for those clinicians in the APM entities. For the MIPS CQMs and ECQMs, the quality data must be aggregated prior to submitting those files to CMS. We will not aggregate data on behalf of an APM entity. So an example of this would be a participant 10 in an ACO. If there are individual submissions for participant 10s, we will not take those individual submissions and aggregate them to the ACO level. The data must already be aggregated prior to sending that data to CMS. Also, one other thing to note is that the submissions should include data for clinicians in your APM entity that have MIPS exceptions and exclusions. So if you have a practice or individual clinician that is below the low volume threshold, for example, and is not MIPS eligible, those clinicians and practices should still be included in your APM entity level data submission. Next slide. So data completeness. We've gotten a lot of questions about what data completeness means for reporting at the APM entity level, or just what data completeness means in general. So just to be clear, data completeness refers to the volume of performance data reported for the measure's eligible population. When reporting a quality measure, you must identify the eligible population or the denominator outlined in the measure specification. We've gotten a lot of questions around, does this mean that because the data completeness requirement is 70%, does this mean that we can only report on or should only report on 70% of the eligible population? So to answer that, the answer is no. You have to report on 100% of your eligible population based on the measure specification. And the 70% data completeness rate is basically your performance met or not met and denominator exceptions. And for the measures under the APP, there are no denominator exceptions. And so the 70% would be based on your performance rate of performance met or not met. Again, when reporting at the APM entity level, as far as data completeness, the data completeness calculation applies to the entire APM entity. So this means that your aggregated APM entity level submission should account for 100% capture of your eligible population across all of the participants in the APM entity. Next slide. Next slide. Okay, so let's talk about some scenarios. So this particular scenario is taken directly from one of the education and outreach documents that we have posted on the QPP website in the resource library. So as we mentioned earlier, the APP can be reported as an individual, in some circumstances, we understand that the measures that are in the APP may not be applicable to certain specialists that would like to report through the APP. And so from a scoring perspective, when that occurs, we reduce the denominator, or the clinician, if it doesn't have any eligible population for a particular measure, we reduce that denominator for that particular measure. And so in order for us to know that a measure is not applicable to an individual clinician or practice that reports through the APP, the data has to be reported in the format as listed here on the slide. And so in this scenario, you have a neurosurgeon who's part of an APM entity that would like to report measure 001, but does not have any eligible population for that particular measure. And so they would like to know what would happen to the measure or how it should be reported. So here you see that in this particular example from the JSON file, that the measure ID is 001. The end-to-end reported status is false. Performance met, you must report this as 0. Performance not met, you should report as 0 as well. Eligible population as 0. The eligible population exclusion as 0, and also the eligible population exception. And so by reporting data in this manner, this indicates to us that eligible population was not met, and that we would reduce this particular measure out of the denominator. Next slide. And this just further breaks down what I just mentioned. So this gives an example of how we would score this particular scenario. As you can see here, measure 001 is not applicable, and so there's no score for that particular measure. However, the clinician would still be scored on the remaining 2 MIPS CQM measures. In each measure, the possible number of scores you can score is 10 points. And so in this scenario, the total denominator would be 20, because we'd be scoring this clinician on 2 measures. And the clinician scored 15 points out of 20. And so this is how we would score a clinician where we've had to remove a denominator because they did not meet the eligible population for reporting the measure. Next slide. Okay, let's talk about aggregating data a little bit more for your APM entity. So in this particular scenario, again, this is taken from the data aggregation fact sheet that we recently posted in the APP toolkit. This particular scenario gives an example of an APM entity needing to report the quality ID 236, which is controlling high blood pressure. In this scenario, we have one APM entity that is composed of 4 10 NPIs, so 4 clinicians. There's also one additional clinician that does not or is not a participant in the APM entity. Next slide. Again, I'll just reiterate that the APM structure here is an APM entity that consists of 4 10 NPIs. And then there's one non-APM participant that is outside of the APM entity. And the patient meets the criteria to report the measure, and so they are eligible for this measure to be reported on their behalf. Next slide. Okay, so here, this is an example of how we, or a method in which the data should be reported. So you can see here that for this particular patient, there are 5 different patient encounters. 4 of the encounters occur within the APM entity. So the patient saw 4 clinicians that are participants in the APM entity and 1 that is not. So at each office visit, we capture the blood pressure. And as you can see, the one that is last in the APM entity is the one that should be reported. And so this means from a data collection perspective that data should be deduplicated prior to sending the data to CMS for reporting, because you would only report once or report the one blood pressure measure the one time, and it should be the most recent. The last occurrence of the blood pressure happens outside of the APM entity or ACO. So that's not eligible to be reported. You would only report on the one instance that is the most recent, and it occurs within the APM entity or ACO. Next slide. This basically just summarizes what I just mentioned on how you would report the data, that the last encounter of the year that is not associated with the APM entity would not be reported, but the last encounter that is associated would be reported just the one time. Next slide. All right, this is the third scenario, again, taken directly from our public-facing documents that are available in the APP toolkit. So this particular example is a singleton APM entity that participates in the shared savings program. As part of their participation in the program, they must report the APP, and this just states that they have two ways of doing so for reporting the MIPS CQMs. They can report directly to QPP using the QPP website and by uploading a QRDA3 file, or by uploading a QPP JSON file. Also, there's the ability to convert your QRDA3 file into a JSON format. And we have resources available that kind of walk you through the process of doing that. Next slide. The final scenario is a multi-10 APM entity that participates in the shared savings program. Again, as part of their participation in SSP, they have to report the APP. However, in the scenario, they are attempting to use QRDA3 files to submit aggregated data. And I think the important item to note here is that since we are requiring that you submit deduplicated data, and that overlapping patients are not identifiable through QRDA3 files, you would actually need beneficiary level data in order to identify, the dupes for patients. And so the QRDA3 file is not an appropriate starting point for doing so. So if you have a bunch of your participant 10 that are providing you with summary level QRDA3 files, you would not have the ability to actually deduplicate data based off those summary files. You'd actually need beneficiary level data. Next slide. Next slide. All right, so briefly I'll touch on APP scoring. So historically, under the APM scoring standard, the quality performance weight was 50 points, or 50% of the score. Cost was reweighted. Improvement activities was 20 points, and promoting interoperability was 30 points. So that scoring structure still exists under the APP. So quality is still 50% of your score. Cost is reweighted. Improvement activities is still 20%, and promoting interoperability is 30%. So in terms of the category weights, the APP aligns with what we've done historically under the APM scoring standard. Next slide. So we briefly touched on the fact that individuals, groups, as well as APM entities can report through the APP. The scoring breakdown is a little different because of measures being applicable to individuals versus groups and APM entities. So if you're an individual that is reporting under the APP, your total points that you can earn for quality is 30 points, and that's based on the 3 required ECQMs or MIPS CQMs. You will not be scored on the hospital-wide measure because it's not applicable to individual clinicians. CAPS is not applicable to individual clinicians, as well as the MCC measure. If you are a group or other APM entity aside from SSP, you can earn up to 50 points for the quality category, and that score would be based on the CAPS measure, as well as the HWR, MCC measure is not applicable to groups or APM entities aside from SSP ACOs. And then lastly, if you're an SSP ACO, you can earn up to 60 points based on the 3 CQMs, the CAPs, and the 2 administrative claims measures. Next slide. So the previous slide kind of talked about the quality performance category. So this talks to the improvement activities performance category. So in the past, historically, as we've done under the APM scoring standard, if you receive your score under the APP, you will automatically receive full credit under the improvement activities performance category. You're not required to submit any additional improvement activity data. You will receive full credit under that particular category. Next slide. Okay, promoting interoperability. So for promoting interoperability, as in previous years, promoting interoperability is submitted at the individual or group level, but not the APM entity level. So when reporting the APP as an APM entity, MIPS eligible clinicians in the entity must still report their PI measures as an individual or as a group. And we score over those required measures just as we do for other individuals and groups in MIPS. And we then take those submissions and create, well, if you're reporting at an APM entity level, we would take those submissions and create an APM entity level score. And we would award the highest of that score to each individual clinician in the APM entity, and that's would be used to generate the APM entity level score. Next slide. Next slide just kind of breaks down how final scores are determined and payment adjustments associated with those final scores. So for 2021, if your final score is between 85 and 100 points, either at an individual, group, or APM entity level, you will receive a positive MIPS adjustment and would be eligible for an exceptional performance bonus. If you score between 60.01 points and 84.99 points, you will receive a positive MIPS payment adjustment. If you score at the 60-point level, you'll receive a neutral MIPS payment adjustment, 15.01 points to 59.99 points. You'll receive a negative MIPS adjustment between -9% and 0%. And then up to 15 points, you'll receive a negative MIPS payment adjustment of 9%. Next slide. Okay. So that's
all right. I'll take it from here, Damon.
Thanks, Corey.
Yeah, I'm going to add something in here just to talk about the resources. Thanks, Damon. Thanks, Brittany. Thanks, Sabrina. To date, we discussed a lot, and I'm watching the questions, and I just want to be open and honest with you guys that this is a lot of information. So we understand that, and because of that, we've provided time today to answer questions. So let me share some resources with you that may be helpful. Again, this is a summary. So we hope that one of the questionnaires or respondents say that they're confused now more than ever. And I'm being open about that because this is a summary of all the information we have to offer. So we hope to answer many of your questions today. We are going till 3 o'clock, so we have about 49 minutes. So we go to the next slide, please. So there are many resources. Not only do we have the website, qpp.cms.gov, and as you go under the MIPS side of the website, at the very top of the banner, you'll see a MIPS drop-down. You can find information about the APP, the APM Performance Pathway. In addition to that, we have a zip file of APP resources under our resource library. That can be also found at the very top under our banner and just do the drop-down for resources. In addition to that, we have MIPS CQM and ECQM measure specifications that are available to help you understand what the requirements are and some of the idiosyncrasies of each of the measure specifications. But today, the focus is to make sure that these resources, although they can be read, that you can actually speak to some of CMS staff and our our specialists here that are experts in this area. So hold on, and I'm going to pass it to Ketchum so that you can lead us in our question and answer period. Thank you.
Thank you, Corey. Before we start with the Q&A, let me just quickly answer one question that we did have come through quite often, which is, will the slides and the recording be available? And the answer is yes. The presentation recording and a transcript will be posted on the QPP webinar library in the coming weeks. That's qpp.cms.gov/resources/webinars. So with that, we can begin the Q&A portion of the webinar. You can ask questions via the chat box to be read out loud or over the phone. To ask a question via phone, please toggle the green hand icon on your go-to menu and we will unmute your line. So we will start now with some of the questions that have already come in through the chat. First question for the group is, can you clarify the beneficiary level data that would be required / can be used to dedupe the data?
So,
I can.
Oh, go ahead, Stephen.
Yeah, I was going to say, if you want me to tackle this one, I can.
Sure.
So essentially, the beneficiary level data that you would need to have in order to report these measures is going to be date of service, what type of services were actually applied, what the claim lines were actually billed, because that will help you determine each one of the populations associated with the measures. Going back to kind of what Damon was saying in the examples he provided. So, if you have a neurosurgeon that is not billing as part of the claim line, that they're treating somebody for diabetes, and at that point, that would not be an eligible instance. So those are the type of, encounter codes that you would need to see as part of the information that you would gather. And then basically from a chronological order, you would then organize the patients to figure out the most recent visit for the measures being reported, since that is the requirements of the 3 measures that are reportable.
Thank you, Stephen. Tracy, we are going to unmute your line now. If you'd like to ask your question, your hand is currently raised. Tracy Arhen.
Oh, I'm sorry. I raised my hand by mistake. I was trying to get to the chat. Thank you.
No problem. Okay, we'll go to Tammy Bowen. Your hand is raised. We'll unmute you now.
I think
Tammy
lowered her hand.
Okay, no problem. We can go back to the chat then and ask some of these aloud. Question, if the Mssp ACO is above the QP threshold, do the practices or ACO still need to report promoting interoperability or just attest to cert?
If an ACO is has earned QP status, and assuming that there's nobody in the entire ACO who is not a QP, then yeah, they don't need to report promoting interoperability. They just need to report to you need to attest to cert use. Just want to flag though that just because your ACO has QP status doesn't necessarily mean that every eligible clinician in every TIN in that ACO is going to get QP status. There are, some weird things that happen sometimes where someone misses a snapshot date or they're not an eligible provider type. So just make sure, double check before you decide not to report PI. Make sure that everyone has gotten QP status so that you don't leave those people with no PI score, because then they'll get a 0.
Thanks, Brittany. We've had several questions about the 30th percentile. So can you please elaborate on the 30th percentile and the goal of meeting the quality performance?
Hi, it's Sabrina. I can take that one. So I just want to start with how the quality performance score will be calculated. So each ACO's quality performance score would be calculated using the ACO's performance on the measures that they would report under the APP, along with any applicable MIPS bonus points and quality improvement points. So once we have calculated each of the ACO's quality performance score, if the score is equivalent to or higher than the 30th percentile across all MIPS quality performance category scores, then we would consider the ACO to have met the quality performance standard for PY 2021. And if the score is below the 30th percentile, then we would consider the ACO to not have met the quality performance standard. And then there are a few questions about, what does it mean to meet or not meet the quality performance standard? So ACOs, if an ACO meets the quality performance standard, then that means that the ACOs are eligible to share in savings at the maximum sharing rate. ACOs in two-sided models would share in losses based on their quality score or at a fixed percentage based on track. For ACOs that do not meet the quality performance standard, it means that they would be ineligible to share savings and would owe the maximum amount of shared losses if applicable. And there are a couple of questions about whether providers would know ahead of time what threshold they would have to meet. So this is an issue that we discussed in the calendar year 2022 proposed rule. And we said that for, just to reiterate what I said earlier, for a given performance year, the 30th or the 40th percentile threshold, the quality performance category score is calculated based on the distribution across all MIPS quality performance category scores only once MIPS final score is complete. So there is no information that can be provided prior to or during the performance year. However, we did note in the proposed rule that for performance year 2018, the MIPS quality performance category score at the 30th percentile was equivalent to 83.9%. And at the 40th percentile, that was equivalent to 93.3%. And then for performance year 2019, the MIPS quality performance category score at the 30th percentile was a little higher than 2018 and was 87.9%, and the 40th percentile was equivalent to 95.7%. And you can go back and find these numbers and this discussion in the 2022 PFS proposed rule. Okay, thank you.
Okay. Next question, how does CMS know if I'm reporting APP as a group or APM entity?
I'm sorry, could you repeat that question?
Sure. How does CMS know if I'm reporting the APP as a group or as an APM entity?
Right. So it depends on how you are reporting. So, excuse me, if you report using the user interface, in order to report at the APM entity level, you'd have to utilize your APM entity level user role. And once you access QPP using that user role, the workflow will take you through a process that asks, how would you like to report, whether traditional MIPS or through the APP, and it'll walk you through that particular process. It mainly depends on the level at which you're logging into the system. The same thing goes on the API side. You would you would report using your APM entity ID or the group 10 that you would be looking to report for. And as far as the API submission for APP, there's a program name that you would have to use, and those specifications can be found in the developer docs located on the QPP website.
Yep, and just to add a little bit more on there, so part of the submission object that would be created would have the entity type, which the valid types for submission are individual, group, or APM entity. So that's where you would kind of signify as well if you're going through the API or if you're uploading a file with your quality measures, you would utilize that entity type field that would really dictate where you're submitting.
Great, thank you to Stephen and Damon. Question, how will the entities eligible for facility-based scoring be removed for purposes of performance standard calculations?
Well, I mean, as a very simple answer, for the upcoming submission period, there is no facility-based scoring. So no one would be eligible to report via that methodology, but in the future, it would be basically analyzed after final scoring assignment, and if the final scoring assignment was utilizing the HVBP score, that would essentially be how the participation would be removed out.
Thanks, Stephen. Okay, how will CMS audit ECQM/MIPS CQM submissions?
I'm not sure if we have the appropriate folks on the phone to respond to that question, but I suggest submitting that to the QPP Service Center, and someone will be able to provide a response, or we could get it to the right person.
Okay. Thank you, Damon. Next question. Is the reporting for all patients, all payers?
Short answer is yes. All patient, all payer data must be reported.
Okay. Next question. Can you please clarify the hierarchy used to determine the final score if a provider has multiple scores and submit data as part of a Mssp ACO and a group level?
Yes, thank you for asking that question. So to get into a little bit more detail on that, I know I said we wouldn't really talk much about virtual groups. If you report to MIPS as part of a virtual group, that is the score you will get because Congress said so, it's in the statute. But almost nobody's in a virtual group. I think there's only like 2 of them in the whole country. Everyone else, if you report to MIPS as an individual, a group, and or an APM entity, each time you report, we will calculate a final score for you. And at the end of it, whichever score is the highest for you as the eligible clinician, that's the score that will be used to calculate your MIPS payment adjustment. If you are part of an APM entity, that could mean that within the entity, clinicians have various scores because they've chosen to report either as an individual or maybe their group had to report for whatever reason. Maybe they have participants who aren't part of your APM entity. So they might have reported separately and you just happen to have gotten that TIMS score. But the hierarchy isn't really much of a hierarchy anymore. It's just you get the best one in pretty much every circumstance, except for the virtual groups.
Okay, thank you, Brittany. Do MIPS APMs have to report improvement activities for 2021?
So, Brittany, I can take this one. So, if you are scored via the APP, MIPS APM participants are automatically given 100% in the improvement activities category. And so you do not need to report any additional improvement activities measures for the category. But that's just, let me just clarify, that's only if you report through the APP. Now, if you're a MIPS APM participant that reports traditional MIPS, because you have the option to do that as well, then you would get 50% IA credit toward the actual IA category. And so if you're looking to improve your score, then you would, or you can report additional improvement activities data.
Thanks, Damon. A follow-up question. You mentioned reporting is for all patients, all payers. Does that include uninsured?
Yes, that includes uninsured. It would be the same standards as for reporting to QPP. All patients that are seen, regardless of insurer type, should be reported.
Thanks, Stephen.
Thanks, Stephen. Another question. How can multi-10 APM entities on different EHR systems submit ECQMs if they can't aggregate QRDA3 files?
So I think that kind of goes back to, Damon's example that he gave, that the QRDA3 is really not the proper place to start with any type of aggregation. You could potentially utilize QRDA1 files, which those are at the patient level to begin the collection. But essentially, you would want to start with the universe of patients seen throughout the year as the starting point for the purposes of reporting.
Great. Thank you, Stephen. Next question. Do we need any reporting as APM other than MIPS and PCF reporting for ECQM?
Sorry, did you repeat that question?
Yeah, that question is phrased a little confusingly. I think I addressed it in a private message, so unless the asker had a follow-up, I think we're okay on that one.
Okay.
Okay, thank you, Brittany. Next question. An ACO is only one that can submit quality via CMS interface, correct? If an NPI in an ACO, that must submit via QPP APM entity.
Was the question whether or not SSP ACOs can only report the web interface measures? If that's the question, that is correct. Under the APP, SSP ACOs are allowed to report the APP using the web interface. All other MIPS APM participants must report via the MIPS CQMs or ECQMs, whether reporting at the group level or individual level. SSP ACOs are the only type of APM entity that can report using the web interface.
Great. Thank you, Damon. Next question. If all Mssp ACOs are required to report via the APP, then would all Mssp ACOs get the 100? I'm guessing that refers back maybe to improvement activities.
Sorry, could you repeat that question one more time?
Sure. If all Mssp ACOs are required to report via the APP, then all Mssp ACOs would get the 100.
I'm not sure if they're referring to the improvement activities category or quality category, but MSSP ACOs are not automatically scored, do not automatically receive a score of 100 under the quality category. However, under the improvement activities category, they would under MIPS scoring.
Great. Thank you, Damon. Just 1 second, we'll ask the next question aloud. So this question is about data completeness. If they report 100% of the eligible population, but only 70% of performance, meaning met, not met, excluded, is this correct? How do you recommend assessing this in the EHR?
Yes, that is correct. Basically, because the system itself calculates the data completeness, it's not something that's a writable field within any type of submission data. So you would have to start with all patients that were eligible for the measure in the eligible population field, and then from there you would have to report at least 70% of performance met or not met in order to meet the data completeness standard.
Great, thank you, Stephen. Next question, if you participate in the OCM or oncology care model, one-sided risk, and are considered a MIPS APM, can they submit additional quality measures to improve their MIPS score since what the OCM is measuring are claims measures?
Yes, that's a great question. Yes, that OCM practice, if you're reporting, I mean, luckily OCM practices tend to be singleton anyway, but if you report as an OCM practice to MIPS on any, you can report on any quality measures that you want. You do not have to report the APP, but you still will get the benefit of having the cost performance category reweighted as long as you report as an OCM practice. So make sure that you're using your OCM entity ID at login, not your TIN. And then you have the option of reporting any quality measures that you want. And actually MIPS requires that you report on at least 6 measures. So you have to report on additional measures.
Thank you, Brittany. Next question. about avoiding duplicate reporting. How would you avoid duplicate reporting on a patient? What, i.e. patients saw more than, oh, sorry, PT. PT saw more than one ACO provider and each has data points on the same measure.
Right, so I think the goal here is to provide data on the most recent. And so you may have multiple instances of that service at different clinicians, but we'd only want you to report the most recent outcome for that measure or measure.
Yeah, I think in addition to what Damon said, a good way of looking at it is similar to if you consider the APM to be like a group within QPP. For those of you that are familiar with that, where basically the patient might be seen by multiple clinicians within the group throughout the year. However, because it's based on the last visit according to the specifications, that would be what you would report on at the APM entity level.
Great, thank you, Stephen. Next question, to clarify, did you say that the comment that CMS will apply the highest MIPS score as the payment adjustment across all submissions? Did you mean apply the highest score to the same 10 with multiple submission types? Or does this mean apply highest MIPS score payment adjustments across all 10/NPI combos? In the MIPS payment adjustment user guide, it states if there are multiple 10s in submissions, then the payment adjustment will follow the NPI 10 combo, which is correct.
Yeah,
They're both correct.
I can answer that if you want me to, Britt.
Sure, go ahead.
Yeah, so every payment adjustment that within QPP is always based off of the 10 NPI associations. So you could have a clinician that works at multiple different practices, and in each one of the practices that they're associated with, their eligibility criteria would be established. So if they're eligible in one group and not eligible in the other group, it's not like there would be a universal application of the payment adjustment across all of the groups. It would be specific to the 10 NPI combination. And then from there, if you are associated with group 1, for example, and you have an APM submission, you have a group submission, and you're eligible individually and you submit individually, that's where Brittany was kind of saying the higher of would be applied. So all 3 of the submissions would be evaluated, and then for that specific 10 NPI combination, the highest score between the 3 of them would be assigned and utilized for payment adjustment.
Thanks, Stephen. Okay, we have a follow-up question. I think my first question was not stated clearly. I represent an Mssp ACO. Our practices will be included in the APP. Why would an individual or 10 in our ACO choose to report for tradition?
Right, so that's a really good question with a couple of what I consider like fun and exciting answers. So why might a 10 choose to report, why might an individual or 10 choose to report traditional MIPS? Or you could even report the APP again as an individual or a group rather than just relying on your ACO score. So the first reason, and I think the one that I expect to see happen the most often, is that you might have, say, a 10 that's primarily one specialty, and that specialty or that group of specialists wants to have their performance based on measures that are more closely tied to their specialty. And so they might choose to report to MIPS so that they can use measures that reflect that specialty. Particularly in the future when we have MVPs, they might want to report on an MVP that reflects their specialty. It could also be the case that you might have, say, a large ACO with very many TINs, and it earns a respectable, but average score, and you might have like one fantastic tin in that group that looks at the score and says, our promoting interoperability score is way higher than everyone else. Our quality performance is way higher than everyone else. We think we can earn more money in MIPS by reporting ourselves. And so they might choose to report the APP as a group because they're going to earn a slightly higher score and be able to get a higher MIPS adjustment that way. An individual might report because maybe they missed the snapshot dates for whatever reason, and so they weren't eligible to get QP status. Maybe the individual had a change in their status within the ACO. Maybe they went from a primary to a secondary provider or vice versa, and so didn't get QP status, or they were unsure of their QP status. Maybe they just wanted to see how they would do, and this could also go for a group as well, just because they know that they already have the ACO score, and so they have a score. They're safe, they're covered. But maybe they want to see how they would do on some other measures, and so you can always report and you'll get feedback and see how you would do on those other measures. So some of it could be more practical reasons. Again, like someone's missed a deadline or a snapshot date, or the 10 things they can earn more money. And some of it could just be that you're trying to push the envelope and experiment and try new measures or things like that. So we hope that this flexibility will actually give us some interesting results in terms of what people are choosing to report voluntarily.
Thanks, Brittany. We can try to go back to some questions from folks that have raised their hands. So let's start with Allison Narvison. We will try to unmute your line if you have a question.
Yeah, hi. So Stephen had previously answered a question regarding aggregating QRDA 3s from multiple TINs, and he stated to perhaps start with QRDA 1s or a different format that has patient level data. So my question is kind of similar to this one. Can QRs aggregate data in a QRDA 1 in multiple formats? So for instance, if one TIN is type delimited, another TIN's data is QRDA 1s, and we have some manual medical record uploads, how does that work for aggregation?
Yeah, so to your point, having all of the data, regardless of the format, is really just knowing that it has to start at the patient level. So tracking, the patient throughout the year is essentially what you're doing when you're reporting. So if when Damon was talking and walking through that, the picture of basically the visits throughout the year, that's kind of the same type of walkway that you would use. So find the last visit that's available, that's an APM participant that has seen the patient, and that would be the reportable outcome for the measures. As to then reporting it, the QPP JSON format would be likely the easiest way to do that, since if you were trying to create a QRDA 3 file, that would basically be impossible, since you would be missing all of the information associated with the demographics potentially. And then from there, it would just be reporting on the instances that are meeting the specifications.
So to clarify, as long as the data is in the registry, regardless of the format that it's sent in, and the registry creates a QRDA 3 that's deduplicated and aggregated and sends it to CMS, that's acceptable by CMS?
I think it would be very challenging to create a QRDA 3 file based off of the way that you would be receiving the information. And also, I mean, at that point, because you would be collecting information, let's say that there was a manual upload, the QRDA reporting has to be considered and reported. So you couldn't really do any type of manual aggregation to the information and still meet the HL7 standard for reporting.
Okay, but if the data was there, that's acceptable, as long as we could get everything that we needed to create the QRDA3.
As long as you have all the information and you're meeting the guidelines for which end-to-end reported is outlined within the final rule, that should be fine.
Okay, thank you.
Okay, thank you, Stephen. Next, we're going to unmute the line of Stephanie Schroeder.
Hi, I was
Stephanie?
wondering if you, can you hear me?
Yes.
Can you hear? Okay. I was wondering if you could provide a little bit more information on the benefits of doing an eCQM over the MIPS CQM. We're coming from reporting the web interface measures, and we'll be transitioning to MIPS CQMs or eCQMs. But I guess I'm still confused as far as the similarities and differences between those two reporting options. If we're coming to the same JSON format or QRDA3 files, could you maybe explain a little bit about the similarities and differences there?
So I guess just to repeat it back to you to make sure I'm understanding the question, are you just looking to determine what the benefits are of each one of the collection types?
Yeah, I mean, I guess I'm trying to determine, in some of the literature, you guys use eCQM/MIPS CQM, kind of in the same context. And it's my understanding it's actually separate reporting options. So I guess I'm trying to determine how those are used within the same context sometimes in the toolkit, even though there's differences in that reporting. So I'm trying to understand the differences in the reporting, I guess.
Sure. I think probably the reason why you'll see them used in combination is because those are really the two reportable options. Part B claims is utilized through actually appending information to your claim data that you submit to CMS. The MIPS CQM or eCQM versions of the measures are measures that would have to be, the data would have to be collected, then reported. So they're kind of just different methods of data collection. The MIPS CQM version is a little bit more flexible with the information because it's not necessarily, needed to be reported as end-to-end, with either a QRDA3 file or a translated QRDA3 file into JSON. You have kind of a little bit more simplicity within that scenario. And also the QPP JSON format is very human readable. The QRDA3 format is not as readable from a human perspective. The file contents are generally a lot larger because they contain a lot of elements associated with the patient scene. However, it's not directly utilized within the QPP program. Hopefully that helps.
Yeah, thanks. I guess I'm just we're trying to determine, which route we're going to go, essentially. So thank you.
Okay, great. Next, we're going to go to, I'm sorry if I'm mispronouncing this, Jitin Pei.
Hey, thanks. So my question is pretty simple and straightforward. So what we've noticed is when it comes to QRDA3 and JSON format, the program code for MIPS app is different. So on a QRDA3 file for individual, it's MIPS_app1_individual, whereas for group is MIPS_app1_group, versus for a JSON file, it's just app1. Question is, why is there a difference?
Yeah, the reason why they're different is because the JSON has that broken out into 2 separate fields, whereas the QRDA3 format has it broken out. It's only in that one field. So you know basically you could report the MIPS individual, which once that gets translated into the QPP format, the QPP JSON format, it would have the entity type as individual and the program name as MIPS. Whereas if you're reporting the APP individual, then at that point it would get translated into the entity type of individual with the program name of APP1. So that's the reason why there is that delineation, so that way you can actually signify the program for which you're reporting within the QRDA file itself.
All right, thank you.
Okay, thanks, Stephen. Next, we're going to unmute the line of Savannah Rittenhouse. Savannah, if you can also unmute yourself. Savannah. Okay, we'll go on. Let's try Holly Clausen. Hi, Holly. I think you're on mute. Holly, do you want to unmute your line? You can ask a question. Okay, we can go back to some of the chat questions then. Let's try Rachel. Sorry, Rachel Grassdorf. Rachel, are you there? We can unmute your line. You have a question about the APP bonus structure?
Yes, can you still hear me?
We can hear you now.
Okay, perfect. So I just have a question about the 3 quality measures that are submitted under the APP submission. I was trying to go through the QPP literature that's out on the website about how bonuses are applied. I know under the web interface for 2021, it's pretty evident that you would get some sort of bonus points for the measures that you submit. I'm just trying to figure out, because they are technically ECQM and CQM measures under the APP method of reporting, if they qualify for end-to-end or high priority / outcome bonus, and how that structure works for 2021. Does my question make sense?
This is Brittany. I'm so sorry. I lost audio for a second. Was that question for me?
Do you mind repeating the question?
Yeah, that's fine. So I know under the web interface, like the traditional method of reporting under the ACO for quality measures, there are some bonus points that are available if you meet data completeness, et cetera. Under the APP method of submission, I'm just curious if there are any bonus opportunities for the quality measures, such as high priority, outcome, end-to-end, because you are technically requiring that we're submitting ECQM / CQM, and that's how a normal MIPS measure would be submitted. Like you would get bonus under normal
Right,
MIPS
yep.
submission.
Mm-hmm. So you're right. Your words were perfect. It's normal MIPS submission. So any bonus points that would be applicable for your submission under the rest of MIPS applies to the APP because it's just part of MIPS. And that means that going forward, and I apologize if you're the one that I was answering your question earlier and mixed up my years, but if you whatever the policy is in 2021 for all of the rest of MIPS is applicable to the APP in 2021. Going forward, as the bonus points are beginning to be taken out of the program, they will also just be taken out of the APP without further specification, because again, the APP is part of MIPS. So when the bonus points leave MIPS, they leave the APP as well, which is just as well because everyone's being scored in MIPS on a budget neutral basis, so it makes sense. And again, the same thing sort of is happening in SSP, where your scores are being compared to other MIPS scores, and so it makes sense that the same bonus points are applicable to everyone.
Okay, so I have sort of a follow-up question. The APP measures, if I'm looking at them, under normal MIPS, some of them are considered outcomes, some of them are just high priority. So are the intermediate outcome measures worth 2 bonus points in that case, or?
I actually, I don't know enough about which measures get how many points off the top of my head. I mean, if you're looking online and it says that, whichever measure is worth 2 points, then it's worth 2 points, even if it's in the APP. But if you want to follow up separately and get more into details, it would just require, a little more research, because that's a level of detail people don't usually, ask me. So it's not on the tip of my tongue.
Yeah, I'm happy to submit a ticket if that's easier.
Yes, that'd be great. Thank you.
Okay, thank you.
Okay, that's all the time we have for questions on today's webinar, so I will pass it back to Corey to conclude.
Thank you guys for joining us today. We really thank you for sticking in there with us. We are having an APM incentive payment webinar later this week, so please look out for it if you have not already received an opportunity to sign up for that. We thank you for the opportunity to answer questions today. We hope this information is helpful, and you can again find resources on qpp.cms.gov. Until then, have a great afternoon, and we'll talk to you soon.